All right, guys. So measuring respiration is a big part of what SLPs do in certain scenarios. Measurements that we take reflect the rate of airflow, so meaning how fast the expiration or the inspiration is happening, and volumes and capacities, which reflect how much air is being sucked in and pushed out during inspiration and expiration. The main instrument that we use for taking respiratory measurements, for the most part, is spirometer. Let's start with an explanation of what an old school spirometer is. So the first generation of spirometer, it looked like this. You had a bucket of water, and inside the bucket of water, there was basically another bucket with a tube running into it. And when you inspired, it would suck air out of the tube, lowering the internal bucket. And then when you expired, it would push air back into, through the tube, back into the internal bucket, raising the bucket. And the up and down motion of that bucket, there'd be a little pencil on it, and it would record that on a sheet of paper, and how much that pencil moved up and down would tell you, the clinician or the scientist, how much air was being inspired or expired. I've tried to find an old school spirometer. These are called wet spirometers because they use water. But they've probably all been thrown into the trash. Here's a video of a wet spirometer demonstration.
Hi, so this is a spirometer, and I'm just going to quickly tell you how it all works. So we have this hose tube, which we're going to stick this thing right in here, which we're going to blow into, the mouthpiece. That's what we're going to blow into. Okay, so inside this tub, there is a ton of water, and this kind of weight measure thingy, I don't know what it's called, but that's okay. Up here we have this chain, and on the chain is this moving piece. So when you blow in, this thing is going to raise because the air is going to come into the tub and lift up. And so this is going to raise and move the chain, which then will cause this to move. And it's going to record how much air you've blown in, or out, rather, sorry. Okay, so I'm just going to quickly demonstrate. You blow, and then you record what your value is. And that's as simple as it is. And with this, we can calculate tidal volume, expiratory reserve volume, and our vital capacity.
But you're not really ever going to use a wet spirometer in a clinical situation these days. At least I don't think you are. I would be surprised. For the most part now, spirometry is a digital function. Computers are used to track the amount of air that's being inspired and expired and the rate of flow. You can even have something I think they make little attachments that even just like plug into your iPhone. So I'm going to bring up a video here of what modern spirometry sort of looks like in the clinic.
All right.
So you see that the spirometer is basically a little attachment to a laptop, so it's mobile. You can carry it around with you.
I'm going to start by just demonstrating this for you.
Okay.
We're going to have this nose clip. It's going to be covering up your nose.
Okay.
Just clip down here just so the air can't leak through your nose. We want it through the mouth. I'm going to have you hold this sensor real still on the side of your face. Okay?
Okay.
I'm going to start new test, and you're going to take a big deep breath in. Big, and fill your lungs up as complete as you can. You're going to put this in front of your mouth. You're going to make a tight seal. It's going to go past your teeth. Your tongue's going to be on the bottom, and your lips are going to form all the way around this, okay? So really tight seal. Nothing can get out. You're going to blast out that air as fast, as hard as you can. I'm going to coach you along the way to keep going, keep going, keep going until we get the full test, okay?
Okay.
You're going to...
So that's sort of what modern digital spirometry looks like. That's the kind of stuff that you guys are going to be doing. I actually have a digital spirometer that I got for the purpose of using it in the education of you guys in this class and in speech science, but then the coronavirus hit. So having everyone come in and breathe through something is like the last thing we want to do now. The measurements that you take with a spirometer, major measurements that we're concerned with are the tidal volume, vital capacity, functional residual capacity, and the rate of an inspiration or expiration. These are terms that we're going to define later in this lecture, but for the moment, tidal volume is essentially the amount of air that you are quietly inspiring and expiring during quiet respiration. There are different ways of explaining what vital capacity is, but I like to think of it as the amount of air that you can inspire after a maximum expiration. So you blow out all the air out of your lungs, all the air that you can, and then you suck in all the air that you can. And that is your vital capacity. And that's important to the SLP because the amount of air that you're able to inspire and the amount of air that you're able to expire, it's the same volume, that's the amount of air that you have available to you to produce speech. In the measurement of respiratory pressure, we usually don't, most spirometers aren't going to measure pressure. You need a manometer to measure pressure. And the classic, the most low-tech version of a manometer is the YouTube manometer, and it looks like this. This guy's going to demonstrate. So it's as simple as that. You push air into the tube, and it displaces the water within the tube, and the amount of displacement of the water tells you the amount of pressure, the amount of expiratory pressure in this example. When we measure respiratory pressure, we do it in terms of the centimeters of water that is displaced within the tube. So a way of saying this is centimeters of H2O. So in order for you to produce phonation, you close your vocal folds over your airway. And when you go to start expiring, to push air between those vocal folds, you have to have 5 centimeters of H2O, that amount of pressure, 5 centimeters of H2O, to be able to displace the vocal folds to produce phonation. So a down and dirty way of measuring respiratory pressure is putting together what is called a drinking glass manometer. Now, this is a trick that you need to carry with you moving forward. I'll mention it again when we get into grad school, but it really is like the clinical equivalent of pulling a rabbit out of your hat. You're going to be at the hospital. You're going to be seeing a client. You're going to be looking at them. They're not going to be able to talk. You're not going to know if the problem is at the vocal folds or is it a problem of respiration. Is it weakness of the vocal folds not being able to come together to make voice, or is that there's not enough respiratory pressure to make the vocal folds vibrate after they're brought together. And to test if the patient has enough respiratory pressure to drive the vocal folds, you run out to the nurse's station, you get a solo cup, paper clip, and a straw. You paper clip the straw to the side of the cup, and you pour water in the cup, and you put the bottom of that straw 5 centimeters below the surface of the water. Now, you know at this point that for the patient to make bubbles, to blow bubbles through that straw, to make bubbles in the water, for that patient to do that, they have to displace 5 centimeters of water to do that. So you present the cup to the patient and you ask them to blow bubbles. If they're able to push air through the straw and make bubbles, you know that they have enough respiratory support to drive the vocal folds. If they don't, you know that they have a deficit in respiratory support and that you need to target that for therapy. So drinking glass manometer. And no one really uses this. I've never seen any. I was taught this in grad school, and I use it all the time when I'm in a clinical setting. I've never seen anyone else use it, any other SLP. So, pressure is measured in centimeters of H2O. The rate of flow, meaning the speed of expiration or inspiration, is measured in cubic centimeters of air per second or minute, which is cubic centimeters, meaning the volume of air per second that you are pushing out or pulling in. Volume can also be measured in liters or milliliters. Usually, for the purposes of clinic, we measure in cubic centimeters or milliliters. When we refer to the respiratory cycle, we're talking about one inspiration and one expiration. That is one respiratory cycle. Adults complete about 12 to 18 cycles of respiration per minute. We're pretty slow breathers when you compare that to a newborn. If you're holding a newborn baby, if you look at their chest, their thorax, you will see the thorax basically moving like this. That is how quick they're breathing. So a newborn completes 40 to 70 respiratory cycles per minute. CPM, meaning cycles per minute. And the older the child gets, the larger their lungs get, the slower their respiration becomes, until eventually they're an adult and they're at 12 to 18 cycles of respiration per minute. So let's talk about some developmental aspects of respiration. So when that infant is born, at that time, the trachea is complete. It's cartilaginous. It needs to be able to hold open the airway so air can pass in and out. The number of alveoli that the child has in their lungs skyrockets from birth to the age of 8. So they go from about 25 million at birth to over 300 million by age 8. And what's happening here is the lungs are growing. And as the lungs grow, the body is growing with it. And as the body grows, the oxygen demands of the body increase. Your body needs more oxygen. So in addition to the lungs increasing in size to accommodate that demand, that increased oxygen demand, the airways are also going to increase. The trachea, the primary, secondary, tertiary, bronchi, and all the little branches are going to increase in diameter as well. A baby, as I mentioned in the last slide, if you're looking at a newborn, it is breathing rapidly. One of the reasons it breathes so rapidly is an infant does not have what we refer to as a residual volume, meaning as an adult, I've got big normal lungs. Even if I blow all the air out that I am physically capable of blowing out, so I expire all the air that I can physically expire, there's still going to be air left in my lungs that I can't volitionally push out. That amount of air left in my lungs is the residual volume. And even if I blow all the air out of my lungs, my body, my alveoli, is still pulling oxygen from the residual volume and is still dumping CO2 into the residual volume. So even during expiration, even at maximal expiration, for me, my body is still exchanging oxygen and CO2 with my environment. An infant does not have residual volume. So when that baby pushes all the air out of its lungs, there is no air left in there for those lungs to still be working on. So that baby has to take an immediate breath back in. So an infant has to much more rapidly supply the alveoli with fresh air, because every time they expire, they're pushing almost all of the air out of their lungs, and they got to get that air back in quickly so that their body can continue gathering oxygen. One of the first times I taught this class, I had a student. I said this bit about the baby, and she raised her hand and she said, "So what you're saying is you never want to have a breath holding contest with a baby?" And I was like, "Yes, that is true, but I'm pretty sure a breath holding contest with a baby would look like you smothering a baby. So that is not something that you definitely don't want to do that. No breath holding contests with infants out there."